All right. Good afternoon and welcome to all of you in person and online at our February Chiropractic CE seminar. Our first presenter will be Judith Sperling, DPM, followed by some work comp attorneys talking for the second hour from Motaz and CISC. Without further ado, I'm going to give a warm welcome here to Judith Sperling. Thank you very much for joining us today.
Hope that sounded like a lot of applause online. Hi to everybody from home. My name is Judith Sperling. I'm a podiatrist. I work in Golden Valley, Minnesota, which for those of you online is a first-ring suburb of Minneapolis. I've been in practice for, 32 years. Seen a lot of this stuff, and I'm happy to share with you what I know. So you see on my face slide, my clinic is in Golden Valley. I work with the U of M family medicine residents, and they can rotate through my office as one of their electives because a lot of them are going to be in rural locations. So they're going to see a lot of the stuff like bad nails and heel pain, especially. And then for those of you who know, you know, but I'm online as Dr. Nail Nipper on YouTube. So please join, subscribe. So I just do that for fun. That's not my day job. Okay, so the first thing is a lot of people want to know what is a podiatrist as opposed to a foot and ankle orthopedist or physical therapist like that. So we are licensed and we can do medical and surgical treatment of the foot and ankle. And in the state of Minnesota, we can do soft tissue work up to and including the tibial tuberosity. I have a colleague who's doing a lot of common perineal nerve releases for all kinds of different problems. So soft tissue up to and including tibial tuberosity in that area, and then bone work of foot and ankle. So bunion surgeries. My colleagues who have trained more recently are doing a lot of ankle trauma, foot trauma, stuff like that. They all have ER call. I'm an old timer now. I don't have ER call, and that suits me just fine. Our education is very similar. I tell patients it's sort of like dentists. We have our own school. So it's undergraduate, 4 years of podiatric medical school. Almost all of the podiatry schools now are connected with mainstream medical schools. And so our first 2 years are identical, and many of the basics are taken with the MD and DO students. But then we have 3 to 4 years of residency following that just really focuses on foot and ankle. So let's talk a little bit about heel pain, because I know you all see heel pain walking into your office, and it looks as though between 5 and 10% or 4 to 9% of the population will at some point in their lives have heel pain. And they'll go into urgent care, they'll come see you, they'll come see us, they'll see their primary. And so yeah, we all need to kind of know what's involved with this. I pulled this up, but this is old. It's from 2007, but insurance companies have paid, $300 million for consultation, imaging, treatment of heel pain. So let's be sure we know what we're treating when we're treating it. This is a study that was done on the US military, and I'm not quite sure how to convert 10.5 per thousand person years. But what I know is it's more than your 4 to 9%. These guys are not in the best shoes all the time. Many of them don't have any kind of orthotics in the shoes. And, there's a lot of heel pain. I did a rotation at Fort Benning when I was a student, and I wanted to learn to fix broken ankles, and that's the jump school. So I saw the kinds of shoes that they were wearing back when I was a student. I don't think they've really progressed a lot beyond what they had there. Okay, so we have plantar fasciitis, and then we have everything else. What's in the everything else category that we're going to look at? Stress fractures. We could have contusions. These are the big ones that you're going to see that get misdiagnosed a lot. Tarsal tunnel syndrome, not always a big one. Baxter's nerve neuritis, and we'll get into what Baxter's nerve is. You will see these. Reiter syndrome, heel spurs, the actual spurs that come off the calcaneus, Haglund's deformity. And this is a biggie that I really want everybody to go home knowing how to diagnose this, the peroneus longus tendinitis on the plantar foot, because that almost always gets misdiagnosed as plantar fasciitis. And then you have some other things that we're not going to spend a ton of time on, but okay. So let's clear this up. How do you know just with your history, whether you're dealing with somebody who's really got plantar fasciitis, or is it one of these other things? So plantar fasciitis, they will always talk to you about pain on the plantar or the plantar medial heel. Everything else can be posterior, it can be plantar. Plantar fasciitis is worse after sitting, after sleeping, first getting up in the morning. All these other ones, usually the pain is worse by the end of the day. And then with plantar fasciitis, classic plantar fasciitis, now I'm not talking about a rupture, but a plantar fasciitis will ease up after several steps, and patients will tell you this. So when you're taking your history, you want to check in. Is it worse by the end of the day, or is it the worst when you first get out of bed in the morning? And then with all of these other issues, the pain really does get worse by the end of the day. These are the patients who are like, I'm not going to the grocery store after work because my heel hurts too much. Okay, so then there is the question about, are we dealing with a fasciitis or is it actually a fasciosis? And the fasciosis really is the deterioration of the tissue. And one of my old professors, Dr. Harvey Lamont, really basically said, you know, the histologic findings are consistent with a non-inflammatory fasciosis. Now, the whole world calls it fasciitis. It probably is a fasciosis. For the sake of diagnosing and treatment, it doesn't really change how we do things, whether we call it a fasciitis or a fasciosis. But that's been in the literature quite a bit, and I just wanted to make sure that everybody knows that there is a difference, but how we diagnose and treat it really is pretty much the same. So we all know what the plantar fascia looks like. We have the, how do I get the little cursor thing? It attaches to the anterior portion of the body of the calcaneus. Thank you. And then it splits into three major bands. There's a medial, a central, and a lateral band. True plantar fasciitis is almost always the medial band of the plantar fascia. Sometimes we'll see it here in the central band. Plantar fasciitis doesn't hurt up in the forefoot. It's really in the arch area and back at the plantar or plantar medial heel. Now, this is why, you know, when I explain to patients, the reason that you have this is just the mechanics of your feet. Thank you, mom and dad. It's genetic. You have a foot that's pronated like this. So pronation isn't just up, it's up and out. So you can see that you're putting more tension on the medial side of that plantar fascia where it inserts than you are on the lateral side. That's why plantar fasciitis hurts plantar medially. And yes, you can have plantar fasciitis with someone with a rigid cavus foot, but when you have a pronated foot like this is somebody who is just set up for getting, you know, various foot problems, one of which is going to be the plantar fasciitis. So again, here, the medial band of that plantar fascia, some of the fibers from the Achilles tendon will come down here and become anatomically part of that plantar fascia, which is why calf stretches as well as plantar foot and arch stretches really makes a big difference for the treatment. So for the treatment in my clinic, and again, this is not everybody, this is what has worked for me for the last 33 years. First, we start with just the easiest stuff: ice, anti-inflammatories, and support. Now, you're going to see these patients coming in Hokas and anything else that's soft. But really, what's going to make the difference is to get them out of that pronated position, to get that heel perpendicular to the ground, or maybe even inverted a little bit to where it really wants to function. But if you don't correct the pronation, like you see in this patient, if you can't correct that pronation, you're not going to get rid of the plantar fasciitis. So the first here is support. You know, I know that chiropractors use a lot of foot levelers. Foot levelers, in my opinion, has improved over the last few decades. And I love when people come in and they've tried them and it hasn't worked, and then we can get them into custom orthotics. So the biggest difference is that with the custom orthotics, we can actually put that foot back into varus, put that heel into inversion so that we can decrease that pronation. If that doesn't work, then they can come in, and we have a ESWT, or extracorporeal shockwave therapy. We have a unit in our office, and this is like a gold standard treatment. It works really well. When I was looking to buy the unit, 15 years ago now, probably, I had a patient who was a national level hurdles competitor. So he was a master's. He was an older guy. He had ruptured his plantar fascia. He came in, we put him in a walking cast, a cam walker, and we did this ESWT on him for twice a week for like 3 weeks. And after 2.5 to 3 weeks, we couldn't even palpate the plantar fascia and make it hurt anymore. So if you look at all the studies on pulsed sound wave therapy, they're using it now for bone healing. They're using it now for wound healing, but soft tissue, swelling, inflammation, scarring, this is really excellent. And then I didn't say this out loud, but it's not covered by insurance. And so it's a cash pay. And the reason that that's great for the practice is that if it ever does get approved by insurance, instead of $100 a treatment for it, we'll probably get about $18. So this is, anybody who's interested, you can come talk to me after, but ESWT is awesome for Achilles tendonitis and plantar fasciitis. What we can do that you can't do is the corticosteroid injections. I try and stay away from those. I do them only if the patient is so acute they can't walk and they can barely stand in a walking cast. And then the plantar fasciitis night splints. So the one thing that I would say about those is you don't want the ones like the Strasbourg socks that attach to the top of the toe and pull the foot back like this overnight, because that's just going to stretch everything and hurt your MTP joints. People don't tolerate those really well, and they don't do a great job. The ones we use, are you seeing this on the camera?
Yeah.
Okay, so the ones that we use are rigid, and they hold the foot at 90 degrees while you're sleeping. And I tell my patients, it's going to take you 2 or 3 weeks till you can make it all the way through the night with this thing. You'll wake up, it'll be on the other side of the room, and that's okay. Any time that you can spend in this night splint that holds you just at like 90 degrees at the ankle, that's going to help your mornings significantly. And then if that doesn't work, we can immobilize them. We can put them non-weight bearing for a month. There's some procedures that are not really invasive, or we can go in and do an open plantar fascial release or an endoscopic plantar fascial release, and they're in a walking cast for a month, and then they usually do fine. When people come in and the MRI shows that they've actually ruptured the medial band of the plantar fascia, that's not really a bad thing, because at the end, that's what we would do anyway. They've just auto released it, and you just have to take care of it while it's healing. Okay, so this is one treatment that's used. I'm not going to spend a lot of time on it. This is the 10X is the more common one, and really it's just like it's like a ablation. So it just ablates all the scar tissue, creates, a lot of these treatments, they just take a chronic inflammatory situation and turn it into an acute one, and then your body can come in to heal. Okay, so that was plantar fasciitis. Anybody have any questions? If you're online, feel free to put them in the chat and we can address them, because then we'll move on from classic plantar fasciitis. Okay. Yes.
So I have that on my right leg, and the splint that I got, it holds it from my knee, but I can put it at a 90 degree angle. That's gonna be fine, or does it have to have the rigid on the base of the foot?
Okay, so the question, if you didn't hear it, was he's got a plantar fasciitis night splint for his own use that is rigid on the back part of the leg, but it's not rigid on the bottom. I say, as long as it's not pulling your toes back like this and dorsiflexing everything from the MTP joints, it's fine. So you want to take it from the metatarsal heads, really is where you want that pressure, and bring it up 90 degrees without dorsiflexing the toes. Okay. So a calcaneal stress fracture it's not super common, but I did just want to touch on it here. This is what you'll see on a plain film, but not if it's too early. So these fall into the category of every step is more painful than the step before. They don't want to go to the store at the end of the day because their heel hurts too much. They may or may not recall an injury. Injuries would usually put it into the traumatic fracture category as opposed to a stress fracture. These are usually a sudden onset. They'll say, I was running and the next morning I woke up and couldn't put weight on my heel. Or it'll happen during a run or during a workout. When you're thinking maybe it's a stress fracture, what you can do, and I have a little video of this at the end, but if you compress the calcaneus between your two hands, they will jump out of the chair and want to hit you when it's a stress fracture. Now, if it's a very acute plantar fasciitis, you can also see that kind of acute pain when you compress the calcaneus with your hands. But that is a sign where I will say, you know what, we need the MRI. Let's make sure it's not a stress fracture before we start treating you for plantar fasciitis. So imaging studies, like you saw the X-ray, but you got to remember that the X-rays lag behind. So if somebody comes in and they've had a week of severe just constant heel pain, you're probably not going to see what you saw on the X-ray. Oh, I got to go through them all. You're probably not going to see that for at least a couple weeks. Okay. So just remember that with a plain lateral X-ray, you're not going to usually see the calcaneal stress fracture. An MRI or a three-phase bone scan is really going to be the gold standard for diagnosing that. And then how do we treat it? We just immobilize them in a walking cast if they can put weight on it without pain, or a scooter, knee scooter. Just time is what this takes. And when you're dealing with your athletes, you really have to stress the good athletes are the ones who know when to let their bodies rest. And so it's really important that you tell them this is going to take a while. And then figuring out why did they get it? What's going on with the structure and function of the foot that allowed this to happen in the first place? You get asked all the time, I'm sure you do too, are the minimalist shoes good? Well, they're good for people who have the ideal foot. But for people who have a rigid high arch foot or people who have severe pronation, no, minimalist shoes are just going to cause stress fractures. And so you got to remember that rigid high arch feet, cavus feet, have as many problems as pronated feet. They're just different ones. And so when you have somebody whose foot doesn't pronate at heel strike, that's going to send the shock from that heel strike straight up the skeleton. So these are the people you'll see with the Achilles tendonitis, the stress fractures in the tibia or the calcaneus, knee pain, hip pain, back pain. Okay. Any questions about that one? Okay. Heel contusions. So this and then the peroneus longus tendonitis are the ones. Yes, we have a question. Yep.
Would using a tuning fork help diagnose the stress fracture?
Well, using a tuning fork, I mean, it can. On the tibia, it's usually, or metatarsal, it's usually much more effective way of diagnosing. But I mean, where would you put it on the calcaneus, on the lateral body, so that there's not a lot of soft tissue? Yeah, I mean, that would be one way. You could, if you wanted to not send them for an MRI or a three-phase bone scan. That would be one of the tools you could use. Okay, so the signs and symptoms of the calcaneal contusion, again, not classic plantar fasciitis. Our pain is worse by the end of the day. I see this a lot with long-standing plantar fasciitis, and I will tell my patients, look, you've been walking funny and guarding for so long with this plantar fasciitis that now you've bruised the plantar tubercle of the calcaneus. Is that true? I don't really know. It's a way to explain it, but I do see this a lot where they have plantar fasciitis and the bruising on this heel bone. Again, more painful with increased activity, increased ambulation, hard surfaces, not cushioned shoes. So when you're looking at the heel bone, or if you're looking for this contusion, you're going to palpate directly under that plantar tubercle. So when you take an MRI, what you're going to see like this is that with the contusion in the bone, and remind your patients, bone is living, growing tissue. It can get inflamed. It can get bruised. On the MRI, we see increased fluid inside the calcaneus, which is how that inflammation will show up. But you got to palpate directly on that plantar tubercle, as opposed to plantar fasciitis, where you're palpating a little bit anterior to where that plantar fascia inserts. So directly on the bottom of that tubercle is where they'll feel it. Sometimes you can also feel like a rope-like structure underneath. So they can have a traumatic bursitis underneath this contusion, and that can also be very painful. So the treatment for this, again, ice anti-inflammatories, cushion, cushion, cushion. Now, I love sending people in to try on Hoka's or UFO's recovery slide sandals. UFO's now makes, I'm not getting paid by them, but they now make clogs and slippers and shoes, and they are so squishy and soft that these are a godsend for people with these contusions on the bottom of the heel. The other thing is you have to remind people, unless we're going to put you on a knee scooter or in a wheelchair with your foot extended, this is going to take a long time to resolve. So you got to be patient. I'm talking like it could be 3-4 months before they don't have this contusion pain anymore. Yes, question.
Question online. Do you suggest any specific tennis type shoes, tennis shoes?
You know, in the Midwest, we call them tennis shoes. In Great Britain, they call them trainers. In the East Coast, we call them sneakers. So I tell people that what you want to look for is something with a lot of cushion in the heel. So a running shoe as opposed to a walking shoe, for example. And rather than tell them, for me to keep up on all the bells and whistles of all the different brands, I couldn't do it. I would have to work at a shoe store. So I will send them to the small local running shoe stores and tell them, try not to go on the weekends or evenings when the high school kids are working. Because the people who work there full time, they know their shoes. They will look at you walk. You will tell them, my doctor said I need something with a lot of cushion in the heel, and they'll get you the choices. So I don't recommend the shoe. I recommend the place to go and what to tell them. And then you can work this out between you and a lot of these local running shoe stores. I tell my patients, just tell them I sent you in and that your managers have agreed to give my patients a little discount because I sent them in, and they will give them what they usually call their club discount. It's not huge, but it's something. So yes, another question.
There was a diagnostic question. As a more cost-effective option, could a CT be a good imaging option for stress fractures?
Yes. Are CTs actually less expensive than MRIs? Okay. Okay. So let's see. Why are we not moving forward?
Click out.
Okay, so this is another one that most people don't know about. Baxter's nerve is the podiatry term. I don't know that it's used out in the general medical community, but it is the first calcaneal nerve branch off of the lateral plantar nerve when that nerve comes out of the tarsal tunnel. Now, remember that nerve could branch up in the tarsal tunnel. This is the branching of the medial and lateral plantar nerve. And this nerve runs right up against the body of that calcaneus. So with this nerve, they can have medial nerve pain. It's usually plantar nerve pain that when you palpate the plantar tubercle, they don't have much pain. This one is on the medial side of the calcaneus. And if you, okay, so these are, sorry. So like our other things, if you think about it, with that pronated foot, you're going to be putting tension on that tibial nerve coming out of the tarsal tunnel. So that's going to put tension on both the medial and lateral plantar nerves. And so that lateral plantar nerve will be irritated, and where they'll feel it is like a quarter-sized area on the bottom of the plantar tubercle. Now, just palpating around that area is not going to light that thing up. What you have to do is you'll get good at this after a while, but you kind of figure out halfway up from the posterior calcaneus, right on the body of the medial calcaneus, you push on it, and it takes about 2 seconds, and then their eyes will bug out of their heads. And then you know that you're dealing with that nerve that's irritated. So again, just palpating around is not going to find you that nerve. It's 2 to 3 seconds of pressure directly over that nerve, and there will be no question. So when you find that pain on that medial calcaneus right at that nerve, it could radiate proximally, it could radiate distally. Usually they will feel it on the plantar heel, kind of in the same place where the plantar calcaneal tubercle pain would be. So what do we do for it? All right, so we have to get these people out of pronation. We've got to get that heel out of eversion. So bringing them to neutral, or if their mechanics are that heel is inverted, you can do that with the custom orthotics, put them into a little bit of varus. We can put a little corticosteroid around that nerve. I know you can't, we can. We can use things like the ESWT, you can use TENS, alpha stim, ultrasound, anything that you use to reduce inflammation will work on this. And then ultimately, we can either do a surgical decompression or just remove that little piece of nerve, which will give them about a quarter size of numbness on the bottom of that heel, which is preferable for them than what they've been dealing with. Sorry. Okay. Tarsal tunnel syndrome, not the most common thing that causes heel pain. But again, you remember your Tom, Dick, and Very Nervous Harry anatomy in that tarsal tunnel. So remember, you've got the artery, vein, and nerve that are deep there. And if you percuss over the tarsal tunnel, if they get the positive Tinel sign, or proximal, I think they call it the Velo sign. But if you get that paresthesia by palpating or percussing over the tarsal tunnel, that will tell you. So again, the pain is increased with worst activity. You can't, this is the key, you can't recreate this pain when you're palpating on the plantar tubercle or the plantar fascia, because that's not where it's emanating from. Okay, so again, controlling mechanics is key. Now, you guys are supposedly the biomechanics experts in the medical world. So make sure that you understand how to use your orthotic devices to take people's heels out of eversion and bring them back to neutral or even into varus if that's where they need to be. One other thing I forgot to say when I was talking about the plantar contusions of the plantar tubercles is that these folks, when we make them orthotics, so most podiatrists make orthotics with a rigid plastic shell, and if it's done right, it'll be super comfortable. But with people with these plantar contusions or the plantar fasciitis with the contusion, we cut a hole out right where the heel sits and fill it with squishy rubber material. So they're getting that cushion at every heel strike, but they're getting the control that the more rigid orthotic can give them. So if these orthotics are done right, the rigid orthotics are not the enemy. I've run marathons in them. Yeah, you wouldn't know it to look at me now, but I used to run marathons. And I've run marathons and trained for marathons in a rigid plastic orthotic. And again, if they're made right, they're going to be super comfortable for people. Okay, so for tarsal tunnel, if you need to, you can immobilize them. Again, anti-inflammatories. Now, I don't know if you guys are allowed to talk to people about the over-the-counter anti-inflammatories, or if you have items in your office that you sell that have anti-inflammatories properties. But when somebody's taking ibuprofen, the actual prescription dosage of ibuprofen is 2,400 to 3,200 milligrams a day for an average 70-kilogram person. And so they would have to take 12 of them a day to get the actual prescription dosage. Lower than that, it's going to be analgesic, but it's not going to affect the inflammation. So if you switch over to something like Aleve, which is naproxen, The prescription dosage for that is 1,000 milligrams a day, but the over-the-counter ones are 220 milligrams. So I tell them 2 in the morning, 2 at night. And that's the prescription dosage. But you always have to let them know the number one side effect with any of these is stomach pain, heartburn pain. And if you start to notice that, you stop taking it immediately and call. Was there a question? Oh, no, okay. All right. Okay, so I said that this is one I really want you guys to take away with you when you leave. So peroneus longus tendinitis, if you look at the peroneus longus, remember it comes around the lateral malleolus, dives under the cuboid where there's that cuboid groove right here, and then it goes obliquely up to the first met cuneiform joint plantarly. Now, sometimes it's proximal enough that if you're palpating around the plantar fascial insertion, people will say, ow. But you would be amazed if you start your palpating just proximal to the fifth metatarsal base plantarly, and just draw like an oblique line up to the first metatarsal cuneiform joint, and you palpate along there. If this is peroneus longus tendinitis, you're going to know it. Okay, so that's a skill, another skill to kind of start working on and looking at when people come in with heel pain. So again, worse by the end of the day. Okay, we covered that. And then you can have them, remember your peroneus brevis, dorsiflexes and everts, peroneus longus, plantar flexes and everts. So if you do muscle testing versus resistance with those two motions, they will let you know, oh, yeah, that really hurts. And a lot of times they'll show you the myotendinous junction, which is, proximal to the medial malleolus. They'll go, yeah, it really hurts up in the leg when I do that. And a lot of times these people will have a lot of trigger points and a lot of spasm in the muscle belly on the lateral leg. So that's also a good thing to test and or to palpate around. And it's also, for you guys, a great place to treat for peroneus longus tendinitis. Now, the peroneus longus, if you think back to your anatomy classes or whatever, there's 4 layers of muscles in the bottom of the foot. This is the deepest one. It's right up against the bone. So to go in there and inject or to kind of do any kind of surgery on it is almost impossible because it's so deep in the foot and you would have to cut through all the other muscle layers. This is one we really try to treat conservatively, but you got to have the right diagnosis. Okay, so we covered that. Okay, so again, treatment, if it's acute enough, you get them immobilized, and just give it rest. And for this kind of a problem, you want to have a walking cast that goes up to the proximal lateral malleolus, to the proximal fibular head, because you want to take away the function of those peroneal muscles, which they originate all along the fibula. And so you want to quiet those. So you want one of the high leg casts as opposed to the short leg ones if we're going to do that. Again, anti-inflammatories, ice on the bottom or on the lateral leg, wherever it really is the biggest issue. And then whatever modalities you want to use, they all work. They're all good. And again, you want to look at, well, why do they have this in the first place? What's going on mechanically that caused this muscle/tendon to become irritated. So I hope that you guys watch patients walk in your offices and you look at leg length, you look at, what their subtalar joints are doing when they're walking. I'm amazed how many people come into my office and they'll go, yeah, nobody's ever watched me walk before. And the pathology, once you do it enough, the pathology is right there. I can see in 10 seconds what a lot of these gait analysis labs turn out 30-page reports on. I can see it as I'm watching them walk. So that's really important to getting this resolved. Okay, Haglund's deformity, or what we call pump bumps. So it's on the postero-superolateral aspect of the posterior calcaneus. Was there a question?
Yes.
No, I was saying, I just actually tried a case involving a Haglund.
Oh, this is from one of the attorneys who's coming up next, and she says she just tried a case regarding a Haglund's deformity. Did you, Christian?
Yeah, we do one online. Any specific ESWT units that you recommend?
The one that I have, so they come either like a pinpoint or they come linear or radial, they call it. Mine is a pinpoint unit. It's called the Well Wave. I know there's a few chiropractors in town that have it. It's a German company who decided that the next generation, they were going to call the piezo wave because it is a piezo wave. It's a piezoelectric. So that unit is made by Wolf and they still have reps around here and it's been a great unit. I use it a ton on my patients and it gets great results. So that's the only one I'm familiar with is the one I have, but there's a lot of them out there.
Thank you.
Okay. For the Haglund's deformity, what you're going to notice is that the pain is posterior, not plantar. They wear out the insides of the back of the shoes. So they'll come in and you'll see that like it's all the fabric on the back of the heel counter is just shredded. Sometimes they'll get blisters there. Sometimes they'll get a bursitis. They'll feel better in clogs, sandals, anything where they don't have something rubbing on the back. And there also can be a retrocalcaneal bursa, a traumatic bursa caused by the constant rubbing. So what causes this is when you have a patient with a calcaneal varus or even just a subtalar joint where when you put that subtalar joint into its neutral or best functioning position, that heel wants to sit in a little bit of varus. So what happens is as soon as that heel hits the ground, it very rapidly inverts. It's a compensated rear foot varus. So the second it hits, before their weight can move forward, they're already rubbing and they're already rapidly going into varus. And so the back of the heel is just rubbing against the back of the shoe with all of their weight. And then you remember Wolff's Law. So if it's constantly irritated, it's going to enlarge. Bone's going to enlarge. So what we do is, again, you want to control the mechanics of the foot so that you decrease that rapid, it says eversion, but it's actually an inversion, a rapid inversion of that heel at heel strike. And then, you know, yes, we can do surgery. Quite frankly, I can't tell you the last time I did a surgery for one of these. But the two things that are done for it are here you can see this is a little bit, you can see the inflammation back here in the soft tissue, but you can also see that that area is enlarged. And so you can go in and surgically just resect the enlargement and then get their mechanics controlled. Or this is called a Keck and Kelly osteotomy, where you go in and just change the shape of that calcaneus enough that it's no longer rubbing on the back of the shoe. Pretty extreme, long recovery. Again, I can't remember the last time I did it. Now, when we are thinking of doing surgery for this, or even for a retrocalcaneal exostosis that's going up into the Achilles, you got to find out, is this heel spur in the substance of the Achilles, or with the Haglund's deformity, is the enlargement posterior to the Achilles or anterior to the Achilles, because that will determine, do we have to detach the Achilles to get at it? So it is pretty involved. Again, don't remember the last time I had a patient I had to take to surgery for this, especially with clogs that are, you know, and soft shoes like Allbirds or all these athletic shoes that are now made with the mesh uppers. And, you know, you can usually find a shoe that'll be comfortable for them. Okay. So we've got heel spurs. Yes, question.
So
You can sit. I'll repeat it. That's fine. Yeah. So the question was, is the diagnosis going to be different if the spur is coming off the back of the heel versus the plantar heel? And yes, that is different. So with the Haglund's deformity, that's separate from retrocalcaneal exostosis or posterior heel spur. It's a different diagnosis, maybe the same cause. You know, we keep coming back to mechanics. But yeah, that's different, and sometimes different treatments. I don't have a great severe plantar calcaneal exostosis, but the thing is, if you see these exostoses, do we have to treat them? Do we have to remove them? And the answer is no. how I explain it to patients is that when I see a spur on the x-ray, what that tells me is that this inflammatory process has been going on for a really long time. And the same process that's causing the pain is also causing the spur to form just because of, and this is the visual I use. I go, all right, so your plantar fascia is kind of like the hypotenuse of the triangle. And just with age or increased activity, as that arch starts to flatten, you can see how that would want to stretch this plantar fascia. But the fascia is not stretchy. So what it does is it starts to tug at its insertion to the heel. And the heel bone is trying to strengthen its grip on that tissue, so it'll start to calcify out into it. And that's what we see as the plantar calcaneal exostosis, kind of the same thing for the retrocalcaneal exostosis. Unless that spur is curved up or curved down on x-ray, the spur doesn't have to come out. It's the process that's causing the inflammation and causing the spur. The spur is not causing the pain. Okay, you look like you had a question online.
If there's time. Got a question here on sneaker, tennis shoe trainers. It's now common that they are very built up with a lot of cushion. Does this make sense for long-term regarding the body mechanics and strengthening of the foot, ankle, lower extremity? Question is, do you recommend these high cushion tennis shoes for everyone, even without foot or ankle issues?
No. No, if it's, so I don't come from the side that says we're better off strengthening our foot and getting rid of the orthotics. I use the analogy of glasses. They are not fixing the problem. You are not going to be able to fix the shape of your eyeball. So they're managing the problem for you. And so orthotics are managing your mechanical structural issues. There are some things that you can change with physical therapy, exercises, strengthening, stretching, but for most people, not enough to get rid of orthotics if you need them. So the people I would recommend the super soft, squishy shoes for are the people with the rigid high arch feet that need the shock absorption, that are not getting it from the body, or the people with the plantar calcaneal contusions that just live or die by having the cushion underneath the heel. That answer the question? I hope. Okay. Let's keep going. How am I doing for time? Okay. So your heel spurs, okay, so we talked about that most of the heel spurs we see on x-ray, completely asymptomatic. Again, you don't have to get rid of the spur to get rid of the pain. Okay. All right, so when you're using the ESWT, the Achilles insertion on the posterior calcaneus almost always lights up on just about everyone. But that's, but constant, if someone's got a short gastroc or a short Achilles, and they pronate, these are the people where you're going to see the retrocalcaneal exostoses. So, what did they find? They found it really doesn't matter. Again, the only ones that I excise are the ones where the plantar spur is curved up or curved down, because those can be painful. Retrocalcaneal exostosis, more frequently excised, but doesn't always have to be. If you can control the inflammation, control the mechanics, they can go without bothering you. Achilles tendonitis, we kind of covered that a little bit. They will talk about posterior heel pain, not plantar. Seaver's disease or the other arthropathies sometimes can be diagnosed, or I'm sorry, Seaver's disease with kids. So again, this is a clinical diagnosis. I'm sorry, I was thinking rheumatoid. But the Seaver's disease, you see them in kids, you know what it is. It's a calcaneal apophysitis. And then radiographically, can you really tell the difference? I don't know. I worked at the USA Cup soccer tournament for years. And when they would come back with these lateral films, we all like to sound like we really knew. Oh, that looks like it's definitely the epiphysis is inflamed. Truthfully, can you really tell? I don't know. But it's a clinical diagnosis. Kid 9 to 14 years of age, maybe, painful right at the epiphysis. And what do? We rest them. And so this would be the MRI, this would be the stir. image where you can see, yeah, it is really irritated. So I guess that might be your gold standard for imaging for calcaneal apophysitis or Sever's disease. This is one I was thinking of. I've had patients where they've come in and I've been able to diagnose, hey, you need to go see a rheumatologist. You've got findings on x-rays that are consistent with rheumatoid or psoriatic arthritis or other things. In the heel, you can see some of these abnormalities and they'll have pain there. And then my favorite slide, the sewing needle or insulin needles, you'd be surprised how frequently we see those. The snail, I've never seen, but just so you know, it occurs. So you kind of want to look for a portal of entry if that seems like what it might be. Okay, so this is the heel exam that that I usually do. Are we going to have any sound on this?
Oh,
So, okay, we don't need it. I can narrate it. So for the plantar fasciitis, you want to dorsiflex that MTP joint for that windlass mechanism that will tighten that medial band. And right there is where you're going to see the pain from a classic plantar fasciitis, right where that inserts. Then you're going to also palpate directly under that plantar calcaneal tubercle. And then that's right how we do the Baxter's nerve, that first calcaneal nerve branch off of the lateral plantar nerve, right up against the calcaneus. And you're going to just push on that again. Just palpating is not going to show it to you. You got to put that pressure and hold it for 2 to 3 seconds. And they'll either have no reaction or they'll want to sit up and punch you because it's very painful. Okay. So medial band of the plantar fascia, calcaneal tubercle, and then Baxter's nerve. So there were 2 things that I forgot to put in that video. Number 1 is the compression. So what I do is I just usually will interlace my fingers and use the hypothenar eminence of my hands and squeeze. And if there's a calcaneal stress fracture, or like I said, an acute plantar fasciitis, they will jump out of the chair. This will be excruciatingly painful for them. And then the other one was that peroneus longus tendon. So again, you start proximal to that 5th metatarsal base, right where the cuboid is, and go up to that plantar aspect of that first metatarsal cuneiform joint. Okay, and that I think is, I don't know what I was saying there, but again, that's the course of your peroneus longus. And that tendinitis can be really painful. I appreciate your time. I hope that I gave you some good nuggets to take back to practice with you. Any questions about any of that?
We do have a couple questions online.
Sure.
What causes spurs on the outside of foot and what are the best treatments?
Spurs on the outside of the foot. I'm not sure what structure you're referring to. We don't generally see exostoses on the lateral foot. You might be looking at an insertional peroneus brevis tendinitis, because that would be on the lateral foot. A Taylor's bunion, or what some people call a bunionette, on the outside of the 5th metatarsal head can be painful, but we don't generally see lateral exostoses.
Thank you. Do you have an opinion on Birkenstock products such as sandals, shoes, orthotics?
Yeah.
This chiropractor's had some success with his patients and self.
Yeah. So for people who need orthotics and they just want to wear sandals in the summer, Birkenstocks are great because they've got really good arch support in them. I usually recommend that they get the kind that has a strap around the back of the heel, because otherwise every step you take, you're gripping with your toes to hold on clogs or loafers or sandals that don't have a heel strap in the back. So you're not going to want to walk the city of Venice in a Birkenstock without a strap in the back. But I think they're a great alternative. I love their over-the-counter arch supports. I think they're one of the best out there that you're going to get. So I don't get paid by Birkenstock, but I think that they're a great product and a good alternative for people in the summer who need support.
Okay.
And that was it.
Oh yeah, you're getting positive feedback and reviews here
Great.
from our online users.
Thank you.
No, she's Dr. Yeah, so